Welcome to the presentation on CDM or chronic disease management. That is what we will be exclusively speaking in today's video. So let us understand what have we learned and what are the evidences so far. What have we learned from the chronic diseases that have been prevalent in our societies for centuries together, and how have we get rid of it? Probably this is the thing that we should be looking for it. So what is the systematic approach to chronic disease management, CDM, and thereby to get started around? So, Castlefeld Health Center in the United Kingdom, which says 15% reduction of unplanned admissions. 15%, remember, reduction in unplanned admission if chronic disease management is being controlled. 31% reduction in hospitalizations. That's a lot of savings. Total hospital beds days fell by 41%, and it means significant saving, better patient experiences, improved integration, and more appropriate referrals as and when on basis. So, veteran administration in USA, what Veterans Administration, if I may say so, sorry, is 35 reduction in the urgent care visits, 50% reduction in the hospital bed days, as the case might be. What am I trying to do is I'm trying to explain the chronic disease management. If it can be managed thoroughly, it is reducing the hospitalization requirement, it is reducing the admissions requirement, and the inpatient referral everywhere else. And I have just quoted to you all the developed countries statistics so that you can extrapolate it to your relevant countries and counties and probably the regions where you are a resident of. Evercare, 50% reduction in unplanned admissions without detriment to the health. Significant reduction in medications, 97% of the family members, and, and career satisfaction. High physician satisfaction as on when on basis, if we say so. Remember, NHS, National Health Services of UK, United Kingdom, adapted Evercare. That's 3% of the target population, 30% unplanned admission for that particular age group. Many admissions are almost avoidable. Let's say UTIs or urinary tract infections and dehydration, perhaps. 55% to 87% of high risk population not accessing the DNs or the social surface altogether. What we are looking out here, the populations which are not accessing the social service or the primary health centers, healthcare centers, probably that is what is the high risk population is. And obviously, yes, the poly pharmacies. So, Northwest London SHA case management released significant capacity. Approximately 29% of the total medical specialty bed days were used by 65 plus in terms of age, and more than 2 plus unplanned admission. So total, remember, this is the specialty bed days were used by 65 plus as in the age group, and 2 plus unplanned admission. Reduction occupied days was approximately 7.5% to 16.5%. Approximately 1.15 million pounds was saved for the PCTs. So reduction of A&E adultents, and which was in about 2 to 3% altogether. And how do we come across with it? This is what we need to understand. So reduction gap, the general practitioner activities as on when on basis, how we look into it. We should be looking everything from 75 plus up to 73% of home visit of OOH out of hospital visits that we are going about it. Reduction in A&E. Remember, we are talking about accidents and emergency adult attendance that comes around it. What are we looking? We are looking at 173,000 pounds of savings per PCT. This is what we need to understand altogether. So what are we looking into it to set up this management cases every now and then? Now, Traditional model is a sickness care model. What is we are looking into it? We are talking about the consultation within 10 minutes. We are talking about general referral, the diagnosis, reassurances, access to other services, review lab, counseling in the lifestyle changes, dealing with acute attack, reinforcement of positive health behavior, talk with family, complete norms, review. It's a whole 360-degree angle that goes around, modify and negotiate care plan. What are we doing with this PCT model out here? PCT is patient care treatment, right? This is my traditional models about the PCTs, the patient care treatment model. But what happens with the chronic care model, CCM? Care is proactive. Care is delivered by a highly specialized healthcare team. Care integrated across time, place, and condition. Care delivered in group, appointment, nurse, clinic, telephone, internet, email, remote care technology. Self management supports a responsibility as an integral part of the delivery system, thereby. So, population management, more than care, more than case management. It is all about targeting the population. It is all about redesigning the process, thereby, as on when on basis, and probably after it, you start measuring the outcomes and feedback. So, yes, the usual care with support is the level one. That's 70 to 80% of the uh, of the CCM population that goes around it, the population that at a higher risk. Then what is about the assisted care and care management that goes around it? We are talking about the level two. This is where we are talking about the high risk member, and the level three is highly complex member, people who have manifestation of the diseases altogether. It's all about intensive care or case management per se. So yes, we are talking about the usual care with the support as in CCM population are concerned. Then probably we take in assistant care and care management, the high risk member, people who shows that they are prone to comorbidities and so on and so forth. And level three, people who are confirmed participant or probably have been diagnosed or showing the manifestation of the disease in an extreme format, they has to be taken into an intensive care or probably case management look out there. Component of CDM, chronic disease management. We are talking about the population management. We are talking about the risk stratification, effective registers and integrated record, evidence-based care pathways as on when on basis, disease management and care coordination. How do we go across with it? So yes, the component of chronic disease management is population management, risk stratification, effective registered and integrated record, evidence-based care pathways, disease management, and care coordination. Component of chronic disease management is self-care, self-management with information and support, active management of the risk patients, primary, secondary, social care coordination as the case might be. We are talking about enhancing the PCTs, the patient care teams, if I'm talking about it. The role through multidisciplinary approach, stratifying the patient for the highest possible risk and probably segregating it and probably addressing the care according to the risk, providing proactive care to the patient with the highest burden of the disease per se, as the case might be. Professional, usually clinical case managers coordinating the care plan, working across boundaries with partnership with secondary care clinics and social services, care team managing the patient journey proactively and seamlessly through every parts of the social care system. That is what is the most important thing to remember out here. That is what we will be looking out here. So basically, what am I suggesting? I'm suggesting nothing but to be systematic. Whenever you start getting systematic, first identify the chronic disease population within the patient care system. Now we need to have who are most vulnerable, who is suffering from chronic diseases as in comorbidities. Population, move the population management as in stratifying the risk as in very severe, moderate, and vulnerable. So probably you stratify for the risk, improve on the disease management as in the care plan, the review, the recall, the reassessment, the care coordination. It has to be for specific people, for specific affected population. You have to address certain specific action. Support the self-management throughout the process. And remember, identify population with the highest burden of diseases, that is 2 plus unplanned admission, 4 plus medics that goes around it. What is 2 plus admission? Is you are expecting a certain stream of patient to follow through during the different cycles of the year, different months of the year. But when there are more than the desired or predictive cycles, predictive numbers of admissions taking place, probably something is going wrong in the system and the society. So apply case management principle and always be proactive. With this, I come to an end of this video. Thank you for watching it.